Hello, everyone. I'm Dr. Jean Connors, a hematologist in Boston at Brigham and Women's Hospital, and I'd like to welcome you to today's webinar hosted by the Anticoagulation Forum titled Understanding the 2023 ACR EULAR APS Antiphospholipid Syndrome Criteria. Today, Monday, September 16th, we are being recorded for other housekeeping issues. I would like to say that we have received a number of pre-submission questions for this webinar, which we will address in the panel discussion. But if you have questions and have not yet submitted them, please use the Q&A box, not the chat function, but the Q&A box to submit them, and we'll try to get to them. Today's panel includes myself and Dr. Jori May. On the next slide, you can see our panel. Dr. Jori May, Assistant Professor in the Department of Medicine at University of Alabama at Birmingham, is also a hematologist. She and I will be moderating today's session and discussions. We have Dr. David Garcia, who is Associate Medical Director of the Antithrombotic Therapy Program at University of Washington Medical Center. He is a professor of medicine in the Division of Hematology at University of Washington and section head of non-malignant hematology. He will be presenting data that we are going to discuss, basically the ACR EULAR diagnostic criteria. And with us today also are Dr. Keith McCrae, Director of Classical Hematology at the Taussig Cancer Institute, Professor of Molecular Medicine, Department of Cardiovascular and Metabolic Sciences at the Cleveland Clinic in Cleveland, and Dr. Stephan Moll, Professor of Medicine from University of North Carolina, Department of Medicine, and hematologist at that institution. So we are going to look forward to a lively discussion about this topic. And David, I turn it over to you.
Thank you so much, Jean, and thanks to the panelists as well as all the participants for being part of today's webinar. I was asked to make a few comments about these classification criteria that were published last year by the American College of Rheumatology and its European counterpart. And I'm going to do that while in the context of talking about the diagnostic challenges that exist for this unusual clinical entity we call the antiphospholipid syndrome. So when we wrote a review article about this some years ago for the New England Journal of Medicine, one of their medical illustrators helped us come up with this beautiful figure, which shows some, I would say, a variety of ideas about how or why it is that these antibodies, which are directed against phospholipid-associated proteins, particularly beta-2 glycoprotein 1, might cause the various complications that we all know occur in antiphospholipid syndrome. And I think most of the folks from AC Forum are particularly interested in the thrombotic complications, especially thromboses that involve medium to large blood vessels, both arterial and venous. But we also know that antiphospholipid antibodies can lead to significant obstetric or pregnancy complications, as well as some other clinical phenomena that are addressed by the classification criteria we're going to be talking about today. Now, this illustration has, an A, a B, a C, and a D, but I would fully admit that the middle part, that is the mechanism by which these antibodies produce the clinical phenomena, are poorly understood at best. And there's lots of smart people still working on how or why it is that these antibodies lead to the clinical picture that we see. But to make the diagnosis of antiphospholipid syndrome, we do need both a combination of clinical findings that are characteristic, as well as laboratory findings that define the disorder. And those laboratory findings cannot be present on a single occasion or transient to serve as convincing evidence of APS. They need to be present on 2 occasions separated by at least 12 weeks. What are the clinical features that are needed? Well, as I said, for the thrombotic sort of flavor of this syndrome, we need to have an arterial or venous clot. And as I'll get to in a moment, that clot really should be, to provide strong evidence of APS, that clot really should be occurring in the absence of some other obvious reason or provocation. We might see clues that APS is present if a patient has, for example, mild, otherwise unexplained thrombocytopenia, an unexplained thrombotic microangiopathy involving the kidneys, certain particular skin findings, especially livido-racemosa or reticularis, a lattice-like non-raised erythematous rash involving the skin, or cardiac valves that are thickened or have vegetations that are not explained by infectious etiologies. There is a distinct flavor of the syndrome called obstetric APS, which is characterized by late pregnancy complications, especially preeclampsia, HELP syndrome, fetal death, or intrauterine growth retardation, and possibly by recurrent early miscarriage, although again, the classification criteria we'll talk about today much more strongly emphasize the late pregnancy complications as being strong evidence for APS. A quick word about these two different types of APS. I think it's increasingly recognized now by people who take care of these patients and do research in this area that there are two relatively distinct varieties of antiphospholipid syndrome. And while there certainly can be some overlap, I've tried to suggest in this semi-quantitative Venn diagram that many patients who have obstetric APS do not manifest thrombotic manifestations and vice versa. So I do think it's increasingly important to recognize the different ways that these antibodies can cause pathology. So we're going to be focusing today on talking a lot about the classification criteria and how they should or can be used to help make the diagnosis of APS. And as we've said, half of the picture is the clinical one, and then the other half is the laboratory studies. And this is a source of a lot of confusion for clinicians and clinical providers. So some do's and don'ts. Do test for anti-cardiolipin and anti-beta-2 glycoprotein 1 antibodies. If you're looking for thrombotic antiphospholipid syndrome, certainly pay a lot of attention to the IgG subclass or isotype of these antibodies, and perhaps de-emphasize the IgM subtype. IgM antibodies are more important or better associated with obstetric complications than with thrombotic complications. And for those wanting to read more about that, I would refer you to the citation at the bottom of this slide. And then, of course, do test for the lupus anticoagulant. The serologies, or the first bullet point listed on this slide, are solid phase immunoassays, usually best performed with an ELISA or an enzyme-linked immunosorbent assay, and they can be interpreted and performed in patients receiving whatever form of anticoagulant you choose without any expectation of interference or false positive or false negatives. They can, by the way, be deceiving if tested at a time when there's otherwise powerful inflammatory drivers such as an infection or major trauma, but they're not going to be interfered with by the presence of anticoagulant medications. On the other hand, the lupus anticoagulant I'm going to talk more about in the subsequent slide is a functional clotting series of clotting assays, and they are potentially very significantly associated by virtually any therapeutic anticoagulant medication, at least potentially affected. And so we have to interpret the results of this assay very carefully in someone who's getting it performed while taking one of the anticoagulant medications that you guys prescribe every day. I'm not going to say much about IgA isotypes or antiphosphatidyl or other types of antibodies. And while they can provide some circumstantial evidence of possible antiphospholipid syndrome, they're not considered to have strong enough association with APS to be recommended by most guidelines or used by most experts to exclude or confirm the diagnosis. And so just another quick couple of words about the lupus anticoagulant. So I do think it's important to get into the weeds of this just a little bit and understand what's going on behind the curtain, so to speak, in the laboratory when you order or try to interpret a lupus anticoagulant. And there are theoretically 3 steps that need to be performed to test for this. First, the lab is just trying to determine, might there be a prolongation of a so-called phospholipid-dependent clotting time. The activated partial thromboplastin time in many labs and the dilute Russell Viper venom time are examples of these sorts of clotting times. That is, they are clotting times that when you stimulate the chain reaction of clotting to occur, the enzymes in the reaction need access to phospholipid-associated proteins and phospholipid surfaces. And if there are antibodies against such proteins present, the times will be prolonged. So if you can show that someone has a normal phospholipid-sensitive APTT and Russell Viper venom time, you're finished as far as testing for the lupus anticoagulant because it's not there. On the other hand, if there is a prolongation of one or both of these times, then the next question to ask is, does the prolongation fully correct when you mix the patient's plasma with normal pooled plasma? Why is that important? Well, this is to distinguish the presence of an antiphospholipid antibody or an inhibitor from a simple deficiency in clotting factors. If someone has, for example, a low factor VIII activity or a low factor XI activity, they will have a prolonged APTT, but it will fully correct when you add normal plasma in a 1-to-1 mix. So you need to show a failure of complete correction with mixing to go to the final step, which is step 3. And this is the so-called confirmatory part of the lupus anticoagulant assay, in which the laboratory adds excess phospholipid. So if you now take the original sample of the patient's plasma and add excess phospholipid to the sample, thereby overcoming, at least partly overcoming, the antibody's ability to slow down the phospholipid-dependent chemical reactions, and you show a significant shortening or a high ratio of pre to post phospholipid addition, then you have theoretically confirmed the presence of a lupus anticoagulant. Now, you can imagine that given that the Russell Viper venom time, for example, is a powerful activator of factor 10, Russell Viper venom is a powerful activator of factor 10, or that the PTT is measuring all of the factors in the common pathway as well as the factors in the intrinsic pathway, that the presence of a variety of anticoagulants could alter one or more different stages of these various tests that are performed. And it's for this reason that we suggest not performing the lupus anticoagulant in patients who are taking therapeutic doses of an anticoagulant. This is just a cartoon illustration to again remind us of the steps that we're doing. We're first going to do the mix with 1-to-1 plasma, and then if there's not complete correction, we're going to do the confirmatory stage where we add excess phospholipid. So to make the diagnosis or to classify someone as having APS, historically until recently, most experts have used or relied upon the so-called Sapporo criteria, which again emphasize both clinical and laboratory elements that are shown here in this slide. But the folks who, Doric Erkan and all the colleagues he enlisted to create these new classification criteria, felt that the Sapporo criteria had some shortcomings in that, for example, they didn't adequately recognize the difference between IgG and IgM as being associated or not associated with thrombotic complications. They perhaps didn't sufficiently emphasize the importance of late versus early pregnancy morbidities, and they didn't place enough recognition on small or microvascular clotting manifestations, as well as other laboratory or imaging clues for APS. So the new criteria also try to weight the importance of different clinical and laboratory elements. And I want to just highlight some things here that I think hopefully make sense. For example, notice that venous thromboembolism, of course, serves as clinical evidence for APS. But if a VTE, say a deep vein thrombosis, occurs in someone 1 week after hip replacement surgery, that is not going to be considered nearly as strong of an evidence that a patient has APS as if someone experiences a PE that's totally unprovoked or not associated with a transient major risk factor. Similarly, a patient who experiences myocardial infarction in the setting of hypercholesterolemia, heavy tobacco use, uncontrolled diabetes mellitus, and borderline hypertension is not going to be considered to have as many points for the purpose of these classification criteria as someone, say, a young person with no cardiovascular risk factors who suffers from a stroke. The criteria, again, also recognize points for biopsy-proven microvascular involvement that does not have other explanation. And again, in the obstetric criteria, there's a heavy weighting toward lots of points or clinical certainty for late pregnancy complications, and much less so for the early fetal losses, which we know are more typically due to chromosomal abnormalities than to antiphospholipid syndrome. I would say that cardiac valve abnormalities and thrombocytopenia are clues that are included in the criteria to try to help clinicians recognize this syndrome, which sometimes is not obvious in a patient who's being treated for thrombotic disorders. And then again, the laboratory elements, I think, are hopefully mostly explanatory, but again, there is a de-emphasis of IgM only positivity and more points for higher, stronger positive results when it comes to the solid phase assays. So again, why were these criteria created? Well, their primary purpose is to classify patients who definitely have APS so that those individuals could be enrolled into clinical studies that are testing hypotheses about treatment or the natural history of the disorder. If you don't have a uniform way of identifying a homogeneous population of patients who have a single diagnosis, then it's going to be very difficult to interpret the results of clinical studies because it's kind of garbage in, garbage out problem. So the purpose of the criteria was not really to create new diagnostic criteria, but to increase the specificity for observational studies and prospective trials. I think there's the other goal of the criteria is to recognize that there are different subtypes of APS, and this also may have important implications for research. It might be that our approach to obstetric APS, our therapeutic approach to obstetric APS, should be different from our approach to thrombotic APS and vice versa. Similarly, microvascular APS may have a somewhat different natural history and a different ideal therapeutic approach versus traditional thrombotic APS, where we're talking about medium to large vessels with clot. And then lastly, to de-emphasize clinical or lab elements that don't correlate well with true antiphospholipid syndrome in the way that many of us who have seen it recognize this disorder. Just a quick word about microvascular involvement, and I think we have a number of questions on this already in the pre-webinar submissions. It is important to recognize this, and I've interacted with even hematologists who didn't realize that, for example, diffuse alveolar hemorrhage is a rare but well-described complication of antiphospholipid antibodies that presumably is due to some sort of microvascular pathology. Kidney disease can be acute or chronic, and it's a bit of a diagnosis of exclusion, but it certainly can be attributed primarily to APS, particularly if an otherwise unexplained thrombotic microangiopathy is identified on biopsy. And then probably several of you on the call have seen patients with what's shown in this photo, the so-called livedoid vasculopathy, or characteristic skin ulceration that shows, again, microvascular thrombosis on biopsy and can respond quite well, in my experience, to antithrombotic and particularly anticoagulant therapy. There has been some comparison between the performance of the Sapporo criteria and the newer classification criteria in terms of their specificity and sensitivity for APS. And I think the big picture message is that the newer criteria are more specific. That is, there are going to be fewer false positives if you use the newer criteria, which are a bit more strict and but less sensitive. So depending on, and there's going to be cases that I'm sure we'll probably talk about some today where even those of us on the panel would disagree as to whether someone has definite or possible APS. And so it's difficult to do these kind of sensitivity and specificity studies when it's hard to know what the gold standard is. But the Sapporo criteria are going to be more inclusive, and the newer classification criteria are going to be more exclusive or specific. And so, in summary, confirming or excluding the diagnosis of APS can be difficult in some cases, although I would argue that if you're wondering whether someone truly has APS or not, there's a good chance they don't. That would be my 30,000-foot rule of thumb, because in my experience, most patients with this disorder, it's pretty obvious in both the laboratory and the clinic. And these newer criteria primarily designed to classify patients for the purposes of enrolling them in research studies, be they observational or prospective clinical intervention trials, are still obviously going to be used by clinicians. They can be helpful to clinicians, and they should be familiar to clinicians, if not to necessarily be the final step in your clinical decision-making, at least to give you another tool to help you know whether you should be leaning toward or away from APS in a particular patient's case. Just a quick plug for the AC Forum's new rapid resource on APS. I believe Jori May and perhaps others on the call led the effort to create this rapid resource. It is extremely well done. I had almost nothing to do with it, so I can say that objectively and in a non-self-promotional way. But you can find it at the Centers for Excellence Resource Center, the web address of which I have at the bottom of this slide, and then clicking the ACE Rapid Resources tab. So I think I will stop my screen share now, and maybe our panelists can turn on their video cameras, and I'll turn it back over to Jean.
Thanks, David. What an outstandingly excellent, I don't know how many more superlatives I can throw in there, and clear presentation. Really grateful for your expertise in this area. I would pose to you, though, and then Keith and Stephan and Jori can chime in. You made it sound simple. why is it so hard in clinical practice to make this diagnosis or exclude this diagnosis? I just love your thoughts on that broad question.
Well, I think there's a lot of answers to that question, but I guess I'll start with the complexity of the laboratory testing and the fact that both clinical phenomena, which are common in people who are sick, as well as the medications we use to treat our patients, can interfere with the laboratory testing. And you know, there's so many different proprietary assays, whether we're talking about the immunoassays or the lupus anticoagulant itself, and different labs have different ways of reading them out or interpreting them. And so I think that, I guess my tip there would be to just get to know your own institution's laboratory and how they perform these tests and how their quote unquote normal ranges compare to other labs' normal ranges, and you know, familiarize yourself with the intricacies of that. But I think that's part of why it's so hard.
Thank you. Stephan, any comments on that?
Yeah, I would like to add to that. One of the problems has been that the Sapporo criteria were relatively global. As David mentioned, they could have included IgG or IgM antibodies of moderate or high titer. They had triple, double, single positive patients. So many of the trials, you don't quite know which patient population was studied. And that includes the topic that we'll probably get to, where the question of DOACs versus warfarin comes in. If the triple positive patients were studied, theoretically, they could all have been IgM positive patients, not the very prothrombotic ones. So I think the EULAR criteria are really nice because they differentiate much more in detail which patient population we are talking about.
Thank you. And Keith?
Yeah, I think going back to the original question, I think this is so hard to diagnose because we don't know what the heck this syndrome is. I don't know what it is. I've studied it for 30 years. I don't know what it is. I don't think it's 2 phenotypes. I think it's probably 50 phenotypes, none of which we understand. I think our lab tests for this are crummy. Even triple positivity for antiphospholipid antibodies has an annual incidence of thrombosis of 5%. That means 95% don't have thrombosis. Obviously, we have different opinions on IgM. Stephan, I don't think has a lot of credence for those, but I had 2 patients in my clinic this morning with pulmonary emboli and DVT and isolated IgM antiphospholipid antibodies of 40 who wouldn't be considered to have antiphospholipid syndrome. So am I going to take those patients and say, take this DOAC for 3 months and you'll be fine? No, I'm not going to do that. Because there's also literature looking at IgMs, and you know, if you look across the board, at least in this literature, which isn't great, but 14% or so of series have patients with isolated IgMs, oftentimes older, oftentimes cerebrovascular. So I'm not trying to say that IgM are more important than IgG in any way, shape, or form. I think IgG are more common and probably more significant, but I don't think IgM are at all insignificant. And that's, I think, a major failing of these EULAR criteria, because let's face it, people can say these are for research, but every clinician who doesn't really understand antiphospholipid syndrome, which is most clinicians, is probably going to jump on this and use them for treatment decisions. So I think this causes risks of undertreating, and I think that's a problem. But I think, you know, the bottom line is we need biological readouts that really tell us about processes and thrombotic risk, and we really don't have those.
No, well, thank you, all of you. Before we move to the audience questions, I want to amplify this for a second, because at my institution, I sometimes go around saying what we need, to your point, Keith, is a functional assay like we have for heparin-induced thrombocytopenia, right? We all know that people can develop heparin platelet 4 antibodies, but they don't necessarily activate platelets, and that's where we rely on the serotonin release assay. I don't know, Keith, if you in particular with your lab-based activities. Has anyone tried to find that correlate, the sort of in vitro platelet activation type of assay for APLA, or is that off base or pie in the sky?
Well, no, I think many have tried and many have failed. I think that I think there's a lot of people who have worked on endothelial cells, but those are obviously hard to use as a diagnostic test. We're actually working on some platelet phenotypes now that I think are kind of unique and seem to correlate better with thrombosis than the standard APL test. But again, it's a small number of patients, and problem is it's hard. It's a fairly rare disease. It may not seem like it when we go to our clinic, but it is hard to do when you think about prospective studies of a disease with this frequency in terms of looking forward. You need a ton of patients to show that something really means something, and it's very hard to do those studies.
Thank you. David or Stephan, anything to add to that?
I'm wondering, when we talk about the disease, that sounds like it's a disorder that has a gold standard. And when David talked about sensitivity, specificity, I wonder, how would one even create a gold standard? There is none. What I wonder, secondly, is even patients with less impressive antiphospholipid panels, be it single positive, double positive, less high titers, is that just one of the multifactorial risk factors for DVT-PE rather than a disease entity by itself? So certainly it seems to be a spectrum where you have clearly this is APS, and then you have all these people in between that have some antibodies, and you do wonder, are they prothrombotic? Maybe not as much as the really full-blown picture ones. And then there's a number of people who have antibodies that are clinically irrelevant, as Keith says. When we talk about the disease, I think we need to be clear, what are we really referring to?
Yeah, I would agree with that, because there are patients, particularly the arterial ones, who have recurrent events on anticoagulation that's well managed, and you recognize without a doubt that that's APS. But as you said, the caffeine DVT that happens to appear to have no other provoking factors, and they have, an IgG, say ACL of 60, but it's persistent. What do you do with that? So before all of you answer that, I'm going to turn this over to Jori to start fielding the questions that have been submitted, because I think that may be addressed in the audience questions. Thanks.
Absolutely. Thanks, Jean. And I'm trying to keep up with the chat and hope I'm keeping up with everybody's questions. We'll try to field as many to this great group as possible. But I think you guys have already touched upon a question that keeps coming up. Is so we have patients that maybe were diagnosed with antiphospholipid syndrome based on the Sapporo Sydney criteria, and we now have a new classification criteria, which has been emphasized was designed for research purposes, but was also mentioned that clinicians are turning to. And so particularly we think about those people that have an isolated IgM positivity that previously met the criteria, but doesn't meet the current classification criteria. I wonder if each of you could answer, how you might manage that. How would you manage that patient in your practice? Because I think we'll get different answers from everybody, which I think is really helpful. So I wonder, maybe Stephan first, have you encountered patients like that in your practice? And are you undiagnosing antiphospholipid syndrome, or is it changing for your IgM only patients, I guess?
Whoa. Well, first off, I want to say, for me, antiphospholipid syndrome has never been one patient like the other. It's not you have the syndrome or you don't. It's a degree, as I mentioned earlier, and I've always taken that into consideration. The titer, whether IgG or IgM, which one is more important, I highly esteem Keith, and there can be discussion. But I think I reinforce what I said earlier. It's false to say antiphospholipid antibodies now meet the criteria of the EULAR criteria, and therefore this and that needs to happen. It's a individualized decision. What do I mean by that? So the patient who has a, let's say, DVT, you still wonder about the multifactorial nature. You still have to identify all the VT risk factors, and then look at the antiphospholipid antibody titers. I think it's helpful that now the thrombocytopenia is part of it, the ITP that would suggest this is truly the autoimmune disorder. I think it's helpful to have the cardiology aspects of the valve thickening and the non-infectious endocarditis, because that may be additional reasons that this is the full-blown picture. But it comes down to, it doesn't mean that APS equals APS and always needs to be treated with what some people now say, always warfarin. I go back to the patient and say, you are a clotting nightmare, for example, and I use that term. If they have recurrent clots, and that's much more suggestive of the true APS, or I tell people, look, you are not a clotting nightmare. It took multiple risk factors to come together to clot, but they may still have APS by the EULAR criteria and yet not be so prothrombotic as the one who has a full-blown picture. So I think whether one calls something APS or not, I'm not sure well, it is probably a little helpful, but it's also dangerous, because then people say any APS needs to be treated with warfarin, and that's incorrect.
I wonder, David or Keith, do you have additional thoughts on kind of how you're approaching reconciling the two in your practice?
Yeah, I can make a few comments. I mean, I probably have a little bit different opinion from Keith on IgM. I can't think of a patient where I've, based on sole IgM positivity, concluded that I was going to classify them as having APS. Now, luckily, as I think everybody would agree, and Stephan was kind of alluding to, it often doesn't matter. For example, if a patient has had an unprovoked venous thrombotic event, they theoretically are a candidate for long-term anticoagulant therapy regardless. And then we're just talking about whether you're going to choose an oral factor 10A inhibitor or warfarin. And again, I personally, just personal opinion, experience, would be very comfortable sticking with an oral factor 10A inhibitor if the only laboratory evidence of quote unquote antiphospholipid syndrome is an IgM antibody.
Keith, do you have any additional thoughts on that, or kind of how you manage it in your practice?
Well, I think that as many of us have pointed out, and I particularly agree with Stephan's opinion that every patient's different. And the use of the APS term, as David pointed out, is somewhat arbitrary in some cases. Yeah, I mean, I never want to say, make opinions based on, well, I saw this patient that, but, I've seen many patients with isolated IgMs who have had pulmonary emboli. Does every one of those have to go on Coumadin? More commonly, I see patients who have had a clot, actually were put on a DOAC 4 or 5 years ago and done okay. Am I going to change them to Coumadin? No, absolutely not. If I see a new person who has had an extensive clot and has a reasonably high IgM level, I might start them on Coumadin. But I think every patient is different, and I do wish that we had more solid predictors. I mean, I think that Stephan's, many of you may be familiar with Stephan's sort of thrombotic risk triangle, where everything is synergistic and adds up. I think we do have to consider other risk factors when we talk about the severity or the aggressiveness of our antithrombotic treatment.
Well, thank you all. And I think it's really telling in all of your answers, right? This classification question is really because we have a lot of these questions about how we best manage people with antiphospholipid syndrome. I think this DOAC warfarin struggle is one that I think particularly the clinicians in the audience are feeling as we see through multiple questions asked. And you guys have already touched on this, certainly, of kind of the nuance of individualized decision-making. But I wonder if you could highlight a few things in your decision-making when you're deciding what anticoagulant is right for a patient. What are the things that make you say, yes, this patient needs warfarin, or what are the things that make you say, well, maybe an oral 10A inhibitor or all other therapies in addition to anticoagulation might be appropriate as well?
Well, for me, I think arterial thrombi, particularly if they're cerebrovascular, I almost always use warfarin, sometimes warfarin and aspirin, because obviously in the clinical trials, the DOAC failures were largely arterial and largely cerebrovascular. So I think that's an easy one, at least for me. Maybe not everyone feels the same, but venous, I think, is a lot more equipoise, and I can't really put a formula on it. I think it just makes. It basically boils down to how much do I think the antiphospholipid antibody actually contributed and how severe the phenotype is.
Yeah, I will agree with that. And maybe to get a little more specific or just to supplement it, if the lab evidence is kind of borderline, maybe we have one borderline positive lupus anticoagulant and an IgM anticardiolipin that's moderate positivity, and that's it. And then on repeat, we can't repeat the lupus anticoagulant, and the IgM on repeat is normal now. I mean, just making up an example. That's going to be one consideration, but I'm also looking at, who is this patient? Is this a 28-year-old medical student who runs marathons and shouldn't have had this middle cerebral artery stroke because she has no other reason to have had it? In which case I might hang my hat a little bit on those lab tests, even though they're, not as convincingly positive as I might have liked for clinical certainty. Or is this somebody who's 65 and has other atherosclerosis risk factors, in which case I'm wondering why the neurologist even sent the antiphospholipid antibody studies, and I'm going to place much less importance on them.
Yeah, I'm going to jump in, David, and say I sometimes think I undiagnose APS more frequently than I diagnose it when I see people sent to me with that question, right? And they presented to the ED, or they had some event and someone sent the panel and they were positive, and then someone might have even repeated it, or it's up to me to repeat it. And I think that's part of the difficulty. I do think that it's, when we talk about the triple positive, when we look at the TRAPS trial data, right, I think they did a reasonable job classifying patients. It's unfortunate that the IDMC stopped the trial a bit early, but what struck me about that, and I don't want to divert from the questions, is that no matter what the qualifying VTE event or arterial, either venous or arterial event was to get people the diagnosis, most of the events that recurred were arterial. And so how do we, put that into perspective for some of these patients? I agree, a 26-year-old marathoner does not have the cardiovascular risk factors at a 65, but where do we put that in?
So I want to make one important point, why I'm so critical about the term that we need to use warfarin in APS. With all the 4 trials, the limitation was people were enrolled into the trials who had a diagnosis of antiphospholipid antibody syndrome. That meant they had already been tested twice, i.e. 3 months apart. So they had been on some anticoagulant for at least 3 months before they were enrolled into the trial. And given when these trials were performed, at that time we were using warfarin for patients with antiphospholipid syndrome. So they had been on warfarin more likely than a DOAC. We know that warfarin has a very high failure rate in antiphospholipid syndrome. Tomartel has published a meta-analysis, 2016, I believe, that up to 20% of patients with APS who are on warfarin warfarin fails them, they have a recurrent clot. And people with venous clots on warfarin with APS also have a failure rate, and I think in that study was 6 or 8%. So warfarin has a high failure rate in APS. Would anyone enroll those patients into a clinical trial that compares a DOAC versus warfarin? Most people wouldn't, because a patient had already shown they had failed warfarin. So my argument always is that the 4 trials enrolled patients who had shown that they tolerated warfarin well. So there's a bias towards showing they will do well on warfarin. For that reason, I'm very critical, and I don't agree with a comment that I hear not infrequently. Patient has APS, oh, we should really be using warfarin. For the triple positive patients, it may well be true, and that's much more convincing. The double and single positive patients in these trials were relatively small. There was a trend towards doing better on warfarin, but it was statistically not insignificant. And again, the trials were biased towards showing warfarin is better. So that's the second part of the whole thing is we said the Sapporo criteria grouped everybody into whoever had at least moderately positive tests, single, double, or triple positive, they had APS. So that needs to be considered when we even make the decisions. And then thirdly, Keith mentioned that a number of patients have done well on DOACs for 2 or 3 years. There we don't know whether they do better being switched to warfarin or not, and I keep them on a DOAC. And then finally, a common question these days is when patients present with an unprovoked arterial or venous events, should we immediately do antiphospholipid antibody testing to potentially early discover patients who may have antiphospholipid syndrome? And it's not unreasonable to do. And if they're positive for anticoagulant and anti-beta 2, at least double positive, we could consider warfarin in those, or we could decide on DOACs. There's no data to tell us what to do until we test them back in 3 months. Lots of limitations to those 4 trials, not even to mention that the Apixaban study was small change in protocol. And lastly, and that also takes a little reference to Keith, I tend to also, in true APS and arterial clot patients who are typically young, I tend to use an anticoagulant plus aspirin because arterial clots are made up out of fibrin and platelets. So I try to hit both pathways, and that's supported by some cardiology literature that the combination does better in non-APS patients as well, even though it increased risk for bleeding, but bleeding in the young people is low. So yes, I'm fearful of arterial clots and APS, and I'm more aggressive rather than less aggressive, and there I would choose an anticoagulant plus aspirin. Finally, and that's really where we started off, the lupus anticoagulant is so often false positive, and then patient overread it and make decisions based on a false positive test. That really needs to be considered.
Well, I think your answers highlight Jean's first question, that clearly this is really challenging. And you know, you guys as thought leaders in this area have thought about this a lot. For people who may not see this consistently, it can be very intimidating to make these type of decisions. So your answers here are extremely helpful. I think we have to address, again, for the practical audience members that we have, is managing warfarin in antiphospholipid syndrome. And a question that we got frequently from our audience is, what do we do about point of care INR testing? You know, how do we ensure that we are appropriately anticoagulating our patients when their INR may not be accurate? So I wonder if folks would speak to, first of all, the specific question, point of care INR testing for APS, yes or no?
Qualified, no.
Okay.
I mean, I've had a few patients actually who have come to me and they were doing point of care testing, and I said that's no, but if I will try to actually do on at least 2 different occasions venipuncture INRs and have them do their point of care INR the same day, if not within a couple hours of each other, and see what the relationship is. I mean, I've had several patients who it's almost identical. I've had others who might have a venipuncture INR of 2 and a point of care INR of 6, literally on the same day. So, I mean, certainly I strongly discourage it, starting it. But if I see somebody who's already doing it, I'll at least give it a trial. Or if there's some reason they just can't do venipuncture INRs for one reason, they're traveling all the time, or they live in a very rural area or whatever, you know, I'll give it some consideration.
I agree.
So it mirrors also what I'm thinking, but I would add to it, even the phlebotomy INR can be unreliable. So in the 2 APS patient, I do all 3 tests. I do a factor 2 activity, which as a dilutional clotting test is minimally, if at all, influenced by the lupus, by the antiphospholipid antibodies. So factor 2 activity, a phlebotomy INR, and a fingerstick INR, because in some people it does correlate well. And in rural North Carolina, and I would say in any rural area of the US, it's difficult to use factor 2 levels, for example. So one may want to create a correlation, and then people follow the patient with a fingerstick INR with a somewhat higher INR, as long as it repeatedly has been correlated to a factor 2, or some people use a chromogenic factor 10 level. Then you can ask, well, what is a therapeutic factor 2 level or a therapeutic chromogenic 10 level? That depends on the reagents used. So it's also just like warfarin, it's a very rough assessment of what we do. I use a factor 2 activity of roughly 10 to 25% as a therapeutic, correlating to a reliable INR of 2 to 3.
You know, it is infrequent that the PT INR in the patient with real antiphospholipid syndrome is elevated. I think it's like less than 5%, right? Will have an elevated PT INR. And that's usually the concern with the point of care tests, is that the antiphospholipid that affects the PT will absolutely interfere with the reagent test strips in the machine. We have a large contingency of outpatients here, and as everyone has said, you know, there are some logistical reasons that for many patients, doing point of care testing is important, and not only for quality of life, but even for access. And so we do validate the, you know, and correlate, as many of you do, so to the point of even making the patient bring the machine in and doing it at the same time with the venipuncture. The thing about those machines that everyone should be aware of is that they are very nonlinear once you get outside the therapeutic range, right? So they're, you know, once you get above 3.5 or 4, and they do not correlate with venipuncture very well, because that's not what they're intended for. And if you get too low, so there are a lot of caveats to using that, and we make people test at least 3 times to correlate, and then either try to, you know, if there's no difference, allow them to use the machine, or if there's a subtle difference, to make sure we look at that offset when we're managing them. But it is tricky.
Great. Well, I might ask one last question as we wrap up. I think Jean made mention of the fact that the majority of what she does is undiagnosed antiphospholipid syndrome, and I think I do that very frequently in my practice. So I wonder if you could share examples or tips for, again, folks who may not see this diagnosis commonly. What are the most common things that you undiagnose? So Stephan mentioned kind of the lupus anticoagulant that was checked on anticoagulation that therefore was inaccurate. Can others think, you know, what are the things that our listeners should be looking out for in order to make sure a patient clearly does not have antiphospholipid syndrome?
Jori, mildly elevated titers, or patient carries the diagnosis and you don't have documentation, the diagnosis has just been carried on.
I would say patients tested during acute illness. We all recognize that, you know, like I tell people, you know, kids with strep throat are going to have an anticardiolipin antibody, and lots of college kids still get strep throat, right? So acute illness, thromboinflammation, causation for VTE, that persistently positive process really needs to be there. And one thing that I think we all need to make clear, or at least from my perspective, because I think someone asked this question, it has to be the same antibody that's positive, right? So if you have a positive, moderate titer of ACL, and then and that disappears, and you get a positive beta 2, that's not what we mean by persistently positive.
Yeah, and I'll just toss in the other thing is, again, if the patient had what we would typically consider a clearly provoked, surgically provoked venous thrombotic event, and that's the only clot they've ever had, I would be very reluctant to commit them to lifelong anticoagulant therapy simply because they had some lab evidence of antiphospholipid antibodies. It can be a tricky situation to deal with if the lab evidence is particularly compelling and convincing. I'm not suggesting it's an easy conversation, but I do not think that the standard of care requires that a patient such as the one I described be committed to decades of anticoagulant therapy based on a single thrombotic event.
Yeah, I would agree with that. I think you presented, David, a pretty kind of straightforward case, but there's a lot that are a lot more subtle. And that's, I agree that not everybody does need lifelong anticoagulation, but I don't think we really know who does and who doesn't, which brings up Gene's previous comment on, do we have a bioassay? And then another comment you made, Gene, as well, it's not the same antibody or whatever, but if actually you look at, I'm trying to remember the first author of the paper in Blood, like 4 or 5 years ago, prospective study looking at incidence of thrombosis after stopping anticoagulation. And there were 4 different curves, and the worst curve was like a persistent antibody. And then the second one was, well, different antibodies positive at different times, but they still had significantly higher risk of thrombosis. So what is that telling me? And I honestly don't really know. But I'm not sure that for all of our discussion about these antibodies, I'm not even sure they're the right ones. We know that, this whatever it is, syndrome, there's been antibodies against kininogen. There's been antibodies against vimentin. There's been antibodies against all kinds of things. And we don't really know what they mean because we don't do them in enough people and they can't really be studied. So I guess it gets back to the point where whether we have the right biomarkers, and that, I'm just playing the devil's advocate that we may be, really kind of partially striking out completely here by even focusing on what we know and not what we don't know, which is all we have to focus on, but it is what it is.
Right. Well, I thank you all so much. We could continue to talk about this endlessly, but I think we have come to the end of our time. So we'll wrap up. I'll pass back to Gene to tie us up.
Yes, no, well, thank you everyone for joining us today. We greatly value your participation in the form of questions and just even tuning in and watching. I want to alert you to our upcoming webinar from the Anticoagulation Forum, which has an excellent panel as well for anticoagulation for AF, VTE, and PVT in patients with cirrhosis. Another clinically challenging area in which to practice. We also want to bring your attention to the AC Forum Anticoagulation Boot Camp, which is, you can join us online October 18th through the 19th. I recommend this for all my staff here in a variety of different anticoagulation practices and stewardship. I think it's great for all levels of providers, and there's a lot of excellent information. And last but not least, we'd love to see all of you in person at our annual meeting in Washington, D.C. In April 2025. So check out Anticoagulation Forum on the website. We really appreciate your attention and thank you for joining us today.